Second Wednesday at 9:30. Another brisk day here in central Missouri. Supposed to get to 50 though, so that'll be nice. So we're going to continue on talking about lipid panels and why you should not just pay attention to absolute numbers. So just to review from yesterday, we did a 20-minute little class on LDL particle size and the size of HDL particles, and why that actually is more important than just your total cholesterol level or just your LDL level. HDL is measured directly. Triglycerides are as well. Morning, Eileen, as well as total. So total cholesterol really is calculated, and LDL levels are calculated or estimated. But you can measure particle size, and you can measure apolipoprotein B levels and apolipoprotein A levels. Morning, Wendy. And so apolipoprotein B gives you an idea of LDL size, and we talked about concordance. So if your LDL level is elevated, but your apolipoprotein B level or your particle size is not, that's probably okay, especially if your triglycerides are low. But then if your LDL level volume is high and your apolipoprotein B or your LDL particle size is elevated, that's atherogenic, meaning it can promote atherosclerosis and future heart disease. What's the worst really is sugar and high fructose corn syrup, and that'll be another class where we talk about what you eat having to do with your heart disease risk. We've talked about that before, but I've got another angle to it based on a study of different dietary modifications and what that does to lipid panels. So again, just to review, if you want to stop atherosclerosis, you must lower your LDL particle number. Okay, and remember, the larger particle, so the number, the larger an LDL molecule is, the easier it goes through the arteries. So the small, dense LDL ones are the ones that get through that endothelial cell layer in a vessel and create inflammation after an immune response. And then that's when things get sticky and you get plaque buildup. So a large, buoyant LDL lipoprotein sails right through. Remember, they're taxis. So lipoprotein, LDL, lipoprotein, low density lipoprotein is taking cholesterol to the periphery of the body for use, and then HDL, high density lipoprotein, brings it back to the liver. So they're taxis for cholesterol. Okay. So HDL appears to be protective if it's small, dense particles. So you want your apolipoprotein A to be higher, and your HDL level itself. What you want on LDL is an apolipoprotein or particle number that is lower with more buoyant, bigger particles. That sounds counterintuitive. So when you start talking about high and low, high density and low density, and then you want small, dense HDL particles and large LDL particles, and you want a lower number of particles per se, that gets a little bit confusing. So most of the risk profiles are for cardiovascular risk prevention. So people that are saying, oh, eat a low-fat diet, take your statins, exercise, don't smoke, don't drink, blah, blah, blah. They're focused on LDL, the number. And so they call it, mistakenly, I think, LDL cholesterol. So LDL carries cholesterol. So that number is what they're focused on. But more importantly is really ratios. And again, I'm going to shout out to Tammy Crabtree. She posted about this last week, and that gave me the idea to, okay, let's go over we'll do a couple of classes on why your fasting lipid profile, the one that's traditionally done, doesn't really tell you a whole lot. So there is a ratio, and you can do it yourself. You can have a physician order it. It's all calculated. All you need is a little arithmetic, So you take your lipid panel, which may just have total cholesterol, HDL, triglycerides, and LDL numbers on it. They used to give you VLDL, and they don't seem to do that anymore. But VLDL is similar to LDL. As it gets rid of its triglyceride, it turns into LDL. So the approximation, I told you they don't necessarily directly measure LDL, they estimate it. So they leave out technically the VLDL and IDL, intermediate density lipoprotein, which are closely related and turn into LDL. They just have a smaller number. Okay, so this ratio, it would be total cholesterol to high density lipoprotein. So total cholesterol number divided by HDL number. That ratio is known as the atherogenic or Castelli index. And so the other ratio that you can do, simple arithmetic or division, LDL divided by HDL levels. So you get a fraction, or you're doing a fraction, a division. And so those two ratios are kind of more important components and indicators of vascular risk. And the predictive value for those two ratios, and we got another one we'll talk about as well, is actually greater than isolating LDL or total cholesterol parameters themselves. Okay, so an increase in total cholesterol because of an increase in LDL, so that's total cholesterol divided by LDL is an atherogenic lipid marker, whereas reduced, so that's another ratio, whereas a reduced HDL level is correlated with numerous risk factors, including metabolic syndrome. And metabolic syndrome leads to insulin resistance, which leads to type 2 diabetes, which is 7th leading cause of death or complications of diabetes, and they have an elevated risk of heart disease as well. Okay. So when total cholesterol, HDL, and total cholesterol divided by HDL are compared in a healthy population and in myocardial infarction or heart attack survivors, so the total cholesterol divided by HDL ratio is found to present less superposition of populations. Okay, so when you kind of have to, when you're doing medical studies and statistics and all that, you can't compare apples and oranges, right? So it gives it a high discriminatory power for coronary heart disease using the total cholesterol divided by HDL ratio. And it's got a fairly decent, it's got a predictive capacity, okay? So what does that mean? So I'll give you some numbers. Let's say a person has a total cholesterol of 231, and their HDL cholesterol, or their HDL level, I keep not wanting to say that, their HDL is 42, so that ratio is 5.5. The American Heart Association, and people are looking at ratios and risk reduction, basically say to keep that ratio under 5. Ideally, it would be 2.8 or less. That means you have a lower risk of heart disease if that ratio is less, or it's 2.8 or less. You have an average risk if it's between 2.8 and 5, and once it goes over 5, you start getting a moderate, and then higher numbers means a higher and higher risk of future heart disease. Okay, so 5.5, so 231 divided by 42, so total cholesterol to HDL, that ratio is 5.5. That's a moderate atherogenic risk. So it doesn't say you're going to have a heart attack, you're in trouble, it's terrible, blah, blah, blah. It's moderate. Anything under 5, average. Anything under 2.8, lower risk. So let's say that same person raises their HDL through aerobic exercise. They stop smoking, they use natural fats and fat oils, and their HDL raises to 60. Okay, so that ratio, so total cholesterol stays the same, let's say it's still 231, divided by 60, that ratio is 3.8. Okay, so in Canada, that's basically how they look at it. So this lipid ratio, instead of LDL levels, which is what the United States focuses on, in Canada they look at this lipid ratio as a secondary goal of therapy. Okay, the other ratio that I mentioned, LDL divided by HDL ratio, is as useful as the total cholesterol divided by HDL ratio. So two-thirds of the plasma cholesterol are found in LDL. So total cholesterol and LDL levels are fairly related. Okay, and so like the total cholesterol divided by HDL, the LDL divided by HDL ratio may have more predictive power if you have elevated triglycerides. So we talked about the science behind the way you eat and avoiding sugars and all that from a lecture 2 weeks ago. And the more fat you eat, and this is the physician that says eat natural fat, just eat fat, avoid anything carby, and watch your protein, make sure it's moderate protein, not high protein. And if you eat fat, your triglyceride levels go down. So he talked about what's the normal, what level of LDL should you have, and he brought in the fact, well, it depends on what your particle size makeup is, and then those ratios, and then your triglyceride levels. So if your triglycerides are over 300, they really cannot adequately assess what your LDL level is anyway. So that's not a reliable calculation. So if triglycerides are over 300, your LDL level is kind of a moot point, and you can't really calculate it. So at that point, you use total cholesterol divided by HDL ratio. Okay. So those people that have a high total cholesterol to HDL ratio or an elevated LDL to HDL ratio, and again, you want that one less than 5. I think it's 4.8 on the scale. So pretty much if those ratios are less than 5, those two ratios, then you have an average risk of future cardiovascular events and cardiovascular disease. Okay, so those people with elevations of those ratios have greater cardiovascular risk because there's an imbalance between cholesterol carried by atherogenic and protective lipoproteins. So the LDL that's atherogenic is the small dense LDL particle, and the cardioprotective one is high density lipoprotein that's also small and dense. So you want bigger buoyant LDL molecules and small and dense HDL molecules. Okay. Okay, what about another ratio? So you can order this. You can't just do, hey doc, I need a lipid panel, you're going to get this. You have to ask for it. You have to say, okay, can you measure my apolipoprotein B and my apolipoprotein A-1 ratio? So ApoB, I'll just shorten it. ApoB represents most of the protein content in LDL. It's also present on intermediate density lipoproteins and very low density lipoproteins. And then apolipoprotein A1 is the principal lipoprotein in HDL. So both of those could theoretically provide information for detecting high-risk individuals. So what you would want is a higher apolipoprotein A level, representative of HDL, and a lower apolipoprotein B level, representative of LDL. So the ApoB divided by ApoA ratio is considered probably the best. So and we talked about homocysteine in the past, and none of these studies I'm looking at talk about homocysteine. That might actually, if you had to ask for one test, it would be homocysteine levels. And if those are elevated, then you would want to dive into these others. Okay. So variations of HDL and LDL, of course, happen all the time. Okay, cholesterol, 80% of your cholesterol is made in your body. So ApoA seems to be a more reliable parameter for measuring HDL since it's not subject to variation. So that one doesn't really vary much unless you intervene over time. Okay, so there's evidence to demonstrate that the ApoB to ApoA level is better for estimating vascular risk, even than the total cholesterol divided by HDL level. So that ratio, ApoB divided by ApoA, was stronger than the total cholesterol divided by HDL and the LDL divided by HDL in predicting risk. Okay? So it's really a balance between two completely opposite processes. So ideally, if you had those numbers, you can just put this in, just divide it. Ideally, the ratio of ApoA to ApoB would be 0.7 or less. And so the higher, or specifically under 1, so we'll say 0.7. When you get over 1, that's when your risk starts getting into the moderate stage. Okay? So if you compare this ratios to what's been focused on, which is LDL levels, these ratios have better predictive power, statistically and in clinical practice. Okay, so the total cholesterol divided by HDL and the LDL divided by HDL, and if you have the ApoB divided by ApoA, you can use that. So good predictors of the degree of clinical benefit from lipid-lowering intervention. And remember, you have to lower your LDL particle number and raise the size to get the clinical benefit. Okay. So there are a bunch of risk factors that have been looked at. So from the Framingham Heart Study that's been going on since 1948. So age, sex, smoking, diabetes, high blood pressure, high LDL, low HDL have been analyzed and established as independent cardiovascular risk factors, although more recent research basically says that higher LDL levels, especially as you age, and higher total cholesterol levels as you age is actually more predictive of a longer life. So guidelines for lipid management are based on LDL concentration. Even though the parameters like they use in Canada, the total cholesterol HDL and the LDL divided by HDL are better cardiovascular risk predictors, and those have not been included in most of the studies on lipid management. Okay, so the beneficial use of those as important cardiovascular risk factors is based on epidemiologic studies, which show that those ratios we're talking about have a greater correlation with cardiovascular disease and are better predictors of cardiovascular disease than just doing lipid parameters, your lipid levels. Okay. So, LDL concentration has been the prime index for risk management and main target for therapy. Statins, eat a low-fat diet, etc. Even though you eat a high-fat diet, your triglycerides go down, your LDL will go up, but LDL in the face of high triglyceride is a problem. Elevated LDL with high triglyceride, but elevated LDL with buoyant LDL particles and lower triglyceride levels are actually healthier. Okay, so that's the story on the ratios. Then I told you I was going to tell you about blood tests to determine the risk of coronary artery disease. Most of these that you would have to ask for. Yes, Wendy, it is a math class, but I taught algebra this week, so what do you want? That's what I'm focused on, sort of. Okay, so this is blood tests to determine the risk of coronary artery disease, and this is from the Cleveland Clinic. I'm trying to think see what year it is. I think it's 2018. Okay, so they go through the total cholesterol thing, blah blah. Triglycerides, you get over 500, you're risking your pancreas, so you can get pancreatitis. And then levels of triglycerides are higher if you're heavy. If your BMI is 30 or higher, and you're obese or you have diabetes. And the other thing that raises triglycerides is simple sugars and carbohydrates and drinking alcohol. They say a high-fat diet raises triglycerides, and that actually flies in the face of what the research shows. So HDL, we're talking about all the stuff that's on a typical panel. for lipids. And then complete blood count, you're looking for anemia and you're looking for inflammation. Okay, lipoprotein a, so that's a low density lipoprotein attached to a protein called Apo(a). The other one is Apo(A). So sorry that gets confusing, I know. So higher levels, if you're over 10, your lipoprotein a level, if it's over 10, you have an increased risk of heart attack, stroke, and blood clots. And high levels tend to run in families. So if you have a family history of cardiovascular disease, especially in younger people under 60, you should ask for a lipoprotein a level. Okay. And then there's apolipoprotein B. So Cleveland Clinic has that right. Homocysteine, I was wrong. I didn't think they had that listed, but they do not have apolipoprotein A. So if you had both of those, you would have that ratio. Homocysteine levels, it's an amino acid. If it's elevated, higher risk of heart and blood vessel disease. Ideally, it's under 10. Hemoglobin A1C is to look for insulin resistance, so 5.7 becomes insulin resistance and metabolic syndrome. At 6.5, you have type 2 diabetes. So ideally, you're 5.6. 5.7 to 6.4 is insulin resistance or pre-diabetes. Okay. Fasting blood sugar ideally is less than 100. So elevation means you have insulin resistance, or if you're over 126, I think you are a type 2 diabetic. Fasting insulin level. So higher levels of fasting insulin level is correlated with obesity, high cholesterol, diabetes, heart and blood vessel disease, and stroke. Cleveland Clinic has a normal range of 1 to 24. I always look for under 20. Creatine kinase is a muscle enzyme. This can be elevated from taking medications like statins to lower cholesterol levels. It's also a marker, specifically the MB fraction, that can look for heart muscle damage. Then there's ALT and AST. These are liver enzymes, also can be elevated from almost any medication, but specifically statins and cholesterol-lowering drugs. Fibrinogen is a protein in the blood that helps blood clot. If it's elevated, since blood clots are associated with heart attacks, so an elevated fibrinogen over 300 is a problem. Thyroid studies, Cleveland Clinic measures TSH only. That doesn't tell you hardly anything. Better would be free T4 and TSH, and better than that would be a full thyroid panel, so you could actually graph those out. You want TSH to be less than 2, and then all the rest of the parameters, free T4, total T4, etc., to be right in the 50th percentile on a bell curve. They mention high sensitivity C-reactive protein. It indicates vessel inflammation. So a higher level, meaning greater than 3, higher risk of heart and blood vessel disease. Ideally, it would be 1 or less. Most people with average risk run between 1 and 3. If it's consistently over 10, that's a problem, big problem. Myeloperoxidase was part of the panel that I did with the bad cholesterol that we talked about yesterday, I think. Myeloperoxidase is indicative of inflammation. So higher levels of myeloperoxidase increases the risk of heart attack, stroke, and possibly the need for CABG surgery, coronary artery bypass grafts. And then high levels mean, in a person with cardiovascular disease, means it's getting worse. So that's an aggressive approach to that if your myeloperoxidase is elevated. Vitamin D controls calcium and phosphate levels. Those are used for bones. They're also in muscle. We talked about vitamin D levels and the gastrointestinal system and physiology yesterday. Vitamin D is more than everybody thinks it is. And then there is trimethylamine N oxide levels. It's from bacteria or the microbiome in your gut. So low risk of that is 6.2 micromoles. Higher risk is 10 or higher. So higher levels of TMAO, it's called, increase the risk of heart disease and stroke. This one I learned from an emergency room physician quite a few years ago at Midwest Regional Medical Center in Midwest City, Oklahoma. They were measuring B natriuretic peptide, and now they have the amino terminal pro-brain natriuretic peptide. Okay, it's a protein made in the heart, found in the blood when there's extra strain on the heart. So if you have a higher pressure, they measure this for heart failure and to follow heart failures. So high levels are linked to a higher risk of heart and blood vessel disease and a decrease in heart function. So high sensitivity C-reactive protein like myeloperoxidase and NT-proBNP, brain natriuretic peptide, that guy taught me in the emergency room probably 15 years ago. Serum creatinine to make sure your kidneys are working fine. So those are some blood tests that you can ask for. I'm not saying you're going to get them, but that's kind of how you do it. Okay, now a totally different approach. This is coming from the University of Texas Southwestern Medical Center in San Antonio. This is from 3 years ago, and it's from Science News, and the headline is, "These 5 tests are better predicting heart disease risk." So 5 different little tests, not one of them is cholesterol. Okay, so they're comparing this to standard strategies focusing on blood pressure, cholesterol, diabetes, and smoking history. And they say, quote, "This set of tests is really powerful in identifying unexpected risk among individuals with few traditional risk factors." And remember, I told you in May, most people that have heart attacks have normal cholesterol levels. Probably 75 to 80% of people that have a heart attack have normal cholesterol levels based on those guidelines. Okay, so these are the 5 tests. 1, a 12-lead EKG, and they're looking for thickening of the heart muscle, or what's called left ventricular hypertrophy. Okay, increase in size of the muscle. Number 2, a CT-guided coronary calcium scan. It's a very low radiation imaging test. It takes about 5 minutes. I've had one done. It's done by CT scan. They run about during Heart Attack Prevention Month, whenever that is. They're usually about $50, but they're typically less than $100. And you can order them yourself. You just, you call a hospital, has a CT scanner, and say, I want a coronary calcium scan. Okay, number 3, a blood test for C-reactive protein, indicative of vessel inflammation. So that was on the other list. Number 4, here we go, hormone measurement of NT-pro-brain natriuretic peptide, which indicates stress on the heart muscle. So we just talked about that one. And then this one is hard to get. This is a blood test for high sensitivity troponin T, which indicates damage to heart muscle. So they use this troponin levels to diagnose heart attacks, but the high sensitivity version of troponin fine-tunes that measure and can point to small amounts of damage that can be detected in people who have no symptoms or any warning signs. So for those 5 tests, they're saying those 5 tests are better than all the other predictors of heart disease risk, including those ratios that we were talking about. Okay, so that's kind of a fascinating. They did this on data from a population of 6,621 people from the multi-ethnic study of atherosclerosis, and then another 2,202 people from the Dallas Heart Study. Okay, so that heart study has about 200 published papers just from that population. Morning, Tracy. Okay, so so that was my thing on particle sizes, and then ratios, and then some other kind of exciting things that, especially that UT Southwest Medical Center thing. I've had the CT cardiac index. Mine was moderate risk at 2. I think my level was 212, and that was a few years ago. I've had HS-CRP levels. Mine are in the, I guess, average risk. All of my ratios are in the average risk, even though my doctor, I think I told you guys this, I went in one time with my cholesterol level, and he says, "Well, your cholesterol level sucks. I'm going to put you on Lipitor." And I said, "Over my dead body." So I managed to Just a year and a half ago, I lost 22 pounds and dropped all that, but my ratios were normal. I tried to point that out to him. He didn't know what I was talking about. So now you are armed with some information, and if you have your lipid panel, you can calculate your own little ratios and see where you fall. Those are more predictive. And then all those other blood tests, if you can talk somebody into doing it, fine. If you can't, if your doctor won't do it, I can get them for you from a direct access lab. You just hit me up on Messenger, and I'll show you where to go. You just order them yourself. It comes with a doctor's order. You just have to find somebody to draw your blood. Tracy, who's on here, is wonderful at drawing blood. Maybe she needs to be a roving phlebotomist for direct access labs. That would be good. Okay, so that's it for today. Tomorrow I'll do something else. So we're going to do 3 days this week: Tuesday, Wednesday, Thursday. Friday, we'll see what happens. I did get called in to substitute teach, but I slept through the text so late last night. Otherwise, I would be at the high school teaching English. All right, I'll talk to you tomorrow morning at 9:30, and you all have a great day. I'll see you. Bye.